I'm Gary Miller. I'm the Vice Dean for Research Strategy and Innovation, and it's my pleasure to welcome you to our Data Science and Public Health Summit. As you may know, this is the second time we've done this. The first one was, I say before the pandemic. That was before we really knew it was a pandemic, but it was occurring at that time in January of 2020. And we had hoped to have a second event, but other surges kind of prevented us from doing it. So it's very nice to be able to have this in-person event here. And so what we did 3 years ago, we were very interested in exploring the challenges in data sciences within the field of public health. There was a lot of effort from a medical standpoint and computer science, but really thinking about some of the special problems we have in public health. We really hadn't dug into that. And so at that meeting, we invited representatives from different schools of public health across the country, and actually had 60 different schools represented when we did that 3 years ago. What the goal this time was really thinking about what we need at Mailman. What does our School of Public Health need to do the very best data science-based public health research, education, and outreach sort of things? And so that's really what we're thinking about today. Is we want to come out of this meeting today with some very clear action items of what we need to do to grow as a school, to increase our abilities and be able to really advance the agenda of what we're trying to do in the School of Public Health. So that's why it's much more internal facing, a lot of panel discussion. We want to have very good interaction with the audience, and really thinking about the goals of how we come out of this with having some really clear ideas that we can kind of give back to the various leadership on campus. So for example, there's been pushing, like looking on our research infrastructure, our computer infrastructure, our cloud sort of offerings, and trying to get some strategy at the medical center level, at the university level. And we want to make sure that our public health needs are properly represented in that. And so that's the sort of thing I want to come out of this with, where we kind of have that information and we can have reports and things ready to go for that. So I encourage everyone to be actively engaged during the panel discussions. We'll have people, taking notes and trying to keep track of things. And so, again, it's something we really want to have this high level of interaction. At this point, it is my pleasure to introduce our Dean, Dean Linda Fried, who I think back when I joined about 4.5 years ago, that we were talking about data science quite a bit. And we really knew that it was her vision that we needed to grow this out. And this is one of the sort of outcomes of that earlier vision. And I think it's been among schools of public health, we've been in very good position because of her leadership. So with that, I will turn it over to Dr. Fried.
Thank you, Gary, and welcome to everybody. I am so excited about this summit. And it's my pleasure to add to what Gary just said in welcoming you to the Data Science for Public Health Summit. I'll add a couple of other perspectives. As many of you know, probably everyone knows, this year our school has been celebrating our 100th anniversary. And that's a number, of course, that doesn't come around that often, since this is a numbers group. But while we have taken stock of the immense achievements in terms of driving the health of our population over the last 100 years due to public health, which you can summarize quickly by saying across all of public health's accomplishments, all of the science that's underpinned it, we've added more than 30 years to human life expectancy. A whole new stage of life, if you will, because of that, the summary of all those accomplishments. That's astounding. And so there's much to feel good about, but in this centennial celebration, we are really focused on what the next 100 years demand and what our responsibilities and opportunities need to be able to provide the science, the scholarship, the innovation to drive the understanding we need to create a healthy population in the next 100 years, starting today, and to really lay the basis for translating that into the accomplishments that are needed so that we are adding health to those extended years of life. And considering the wide range of incoming challenges, which are unprecedented threats to health, from the health impacts of climate change to distorted food systems and growing food insecurity, to the issues of how to create health across longer lives, health disparities. I mean, so many really challenging issues that change, and syndemics at the heart of all this. The complexity, the wicked challenges that we're confronted with really demand thinking about the methods and the capabilities we as a field have to bring to the future of health. And leads very quickly to the conclusion that the world needs public health as much or more in the coming 100 years as it did in the last 100 years. And it needs the capabilities and the directions that I look forward to this summit laying out for, certainly for our school, in terms of how public health can lead more effectively through data science that understands health and through the capabilities that we can bring. So, all of these challenges require not integrating many perspectives and from our core responsibilities of prevention and population health, and uniting those, as public health always does, with our foundational commitments to ethics and justice and social justice. And so as we rise to all of these challenges, which bring a level of complexity that I think we never felt so compelled by before, but we never saw so much as something we can leap to handling, both methodologically, analytically, and in terms of applying to these highly complex challenges. I think we're at a moment that needs our A game, and our A game, I believe, can do this, but we have to figure it out. And we have to utilize, of course, all of you, our best and brightest minds, and the very best science. So I think as a number of you who have organized this important summit have said, the analytical tools that can be broadly defined under the umbrella of data sciences and data sciences for health are going to be a major part, I think, of the foundation of the solutions we need. This means broadly that schools and programs of public health have to become facile in the wide range of tools and techniques that fall under data sciences and data science for health, including, of course, machine learning and network science and data visualization and dynamic modeling and so many more things. And we have to be able to utilize, apply, have data science for health drive our ability to both understand and solve our research problems. And as importantly, we need to be assuring that the next generation of scientists, our trainees, are empowered with both the tools of this field and the cognitive framework and broader understanding of how to tackle highly complex problems with big data in valid ways. So we've seen that machine learning and artificial intelligence also have the potential both to do good and to serve bad. That they can introduce serious biases that, rather than advancing humanity, have the potential and the reality of actually accentuating the health and other disparities that we're working every single day to correct and prevent. So as a field, public health has to create training and research programs that prevent these missteps, and I believe provide the guardrails for the rest of society, for the corporate sector, for government, for every sector of society to use, coming from the respected platform of objective knowledge that we represent, united with social justice. So I think we're responsible Academics have this amazing opportunity and flexibility and freedom to say what matters and to put our minds to achieving it, not on quarterly reports, but for the long haul. But we also have the responsibility, I believe, for creating the world's problem solvers and enabling tackling the biggest challenges in the right ways with the right tools. And so today's event is really focused on these issues, and particularly the tools and the foundational principles for our success and how we unite those. So I want to say thank you for being here today. I know that the discussions today are going to advance both our thinking collectively and our goals and our capabilities. And I'm really excited to learn what recommendations you make for the future of data science for health at this institution. So now it's my privilege to introduce the originator of much of what we're talking about today, Dr. Jeanette Wing. Jeanette is known probably to almost everybody, if not everybody in this room. She is now the Executive Vice President for Research at Columbia University, as well as a professor of computer science. She's had an eminent career, and we are the beneficiaries of her ability to think at grand and principled levels simultaneously and in complex ways and find the elegant solutions. Dr. Wing was formerly, as we know, the director of the Columbia Data Sciences Institute, which is where our partnership began, I'm very happy to say. And Jeanette, we are thrilled that you're here to help us launch this important day and looking forward to our ongoing partnership. Thank you.
Good morning, everyone, and thank you, Linda. Thank you, Gary, for those introductions and setting this meeting up. I wanted to get back to Linda's comments, which is when I first came to Columbia, of course, I was trying to promote data science everywhere, but I found Linda a kindred spirit because completely independently, she understood the importance of data and data science for public health. So I immediately connected with her, and we even went to fundraising trips together. And, you know, that was, Linda was so gung-ho about supporting data science that she said, you know, I need a vice dean of research on data science. Oh, I don't remember what the title was at the time, but, you know, she recruited Gary here, and it's just been, a real ride because Gary is such a proponent of data science. He really gets the research aspects, the data analytics. And if you haven't used ChatGPT yet, you have to try it. It's pretty amazing. And I suggest not only will it help you think about the frontiers of research, but also the frontiers of education. So I know you've been reading about it in the newspapers, but do try it out and see what it can do and how it might change your own lives or your children's lives. Okay, so I also am delighted to be here at this summit because at Gary's request, the first summit we held that was data science and public health was an open, you know, broad community summit. And I spoke at that, and it was really a beautiful event. So I'm, again, happy to greet all of you and talk about the importance of data science and public health. I have been pegged specifically to talk about some of the big ideas that are principled, but may not have an elegant solution. With respect to research and data and compute infrastructure. So the big idea is I have always dreamt of a solution for all universities for research and education to really go big in terms of the computational and data infrastructure needed to support not just research, but education as well. I've scaled down that big idea. I am still working on that. But I've scaled that down for Columbia. And it's a big idea for Columbia, which is to think of the future of the computational and data infrastructure we need for research here across the entire university, for high-end AI applications, for scientific computing, for the gobs and gobs of data that all of you produce in your research and education. And the question is, for the future, what is that computational and data infrastructure going to look like? What are the needs that all of you have here at Columbia, at Public Health, in terms of the computational and data infrastructure you will want to use for your research? Right now, we have a modest high-performance computing cluster on the Morningside campus. There are a couple of clusters available to CUIMC researchers. Nothing is integrated. And one of the big ideas that I have for the university is really a centralized resource for the whole university, for the whole research community. And it's not just about cycles, it's about bytes as well. So it's not just about compute, it's about data as well. And this is, of course, relevant to this summit because all of you produce, collect data. You need to analyze it. You need to use advanced techniques like natural language processing, machine learning, computer vision techniques, and so on to do the analysis of all the data that you're collecting to gain the insights that you wouldn't otherwise be able to gain. So, you know, I know there's a session later today specifically on this topic. I strongly encourage you to really brainstorm for the future. What do you need? What will you want to use for the future to advance your research and education? And I have a plant in the audience, Sophie, who will be listening in and taking notes. So I really encourage you to think ahead. This is what I'm doing now, but what are you going to be doing in the future? And it's a hard kind of question to ask because if you had more, you'd be able to do things that you wouldn't even dream of doing now. So it's really think ahead. And I know Linda and Gary are very supportive of this effort. I have in mind certain ways in which the university can help the research community in terms of compute and data infrastructure, but we are not, we being Gasper, the head of CUIT, and I are not going to build something that no one will use. So it's really important that you help us figure out what you need. So on that, I'll end. And thank you very much. Kiros, it's great to see you. I helped recruit you too, so I feel like I really played a role in shaping the future of public health here with the leaders that we have. So have a good summit, and I'm around, all available to answer questions anytime. So especially on this topic. All right, thank you.
So thank you very much, Jeanette and Linda. We were a little bit behind schedule, but you'll notice we have lots of breaks, a lot of buffer time in here. We'll be totally fine today. I want to introduce Kiros Burhani, the chair of Biostatistics, to introduce our keynote speaker. Kiros and Jeff Goldsmith have been really critical in organizing this summit, along with the help of Cam Ming, Xiaolong, and my group. Lauren, there are a lot of behind the scenes things to make all this stuff work. It's been a fantastic team, but Kiros, I'll turn it over to you.
Thank you very much, Gary, and thanks, Dean Fried and Jeanette, for those wonderful remarks. In fact, one of the reasons I came to Columbia and I was very enthusiastic was actually the kind of leadership and really, support that there is for data science in general and data science for health in particular by our institutional leaders. In fact, I remember the first summit that we had was 2 weeks into my job. And it was actually the most exciting way to start my career at Columbia. And since then, because of the centennial celebrations and also the Building Back Better ideas that was actually charged to us by Dean Fried, and data science actually being identified as one of the 5 pillars for the next century for the, for Mailman School of Public Health, a lot of things have been happening. And today's summit was made to be actually internally looking for a purpose, so that we can actually chart where we go as a school and where, how we can shape the, the direction the field is going. As you can see from the program today, it's deliberately multidisciplinary and transdisciplinary. Of course, biostatistics, my field is definitely at the forefront of it in terms of data science for health, but data science is not only about biostatistics or statistics, it's about, entire, many fields in public health and across the medical center and beyond. So the program reflects that. And when we were thinking of a keynote speaker, it was actually unanimous and a very, very, easy choice to think of Professor Xihong Lin to be the keynote speaker for our summit because of her own track record in terms of what she has done in her own career. So today she's going to talk to us with the title Lessons Learned from the COVID-19 Pandemic, the Statistician's Reflection. And she'll tell us, of course, in more detail about her talk. But I would like to say a few words about Dr. Lin, even though I think we'll need hours, if not the whole day, to really introduce her and really lay out the accomplishments that she has done. So her career started with a BSc degree from Tsinghua University in China in 1989, and she got her PhD in biostatistics in 1994 from the University of Washington Department of Biostatistics with Norm Breslow. And her PhD dissertation in bias correction in generalized linear mixed models was actually an early indication of how impactful her work was. In fact, that's actually how I first know Xihong because of this work. And I remember meeting her in 1996, right after our PhD studies, actually. I believe it was in Chicago at JSM. And, very impressive at that time. And of course, throughout her career, she has been a trailblazer. Just to mention some selected areas of research, mixed effects models, non-parametric and semi-parametric regression, statistical genetics, genomics, bioinformatics, etc., just to mention a few. And of course, her career has, garnered lots of recognitions from the field. She was elected fellow of the American Statistical Association in 2000. She was recipient of the Mortimer Spiegelman Award from the American Public Health Association in 2002. This is an award given for someone who is under 40 with impact on public health research. She was a recipient of the prestigious COPS Award, which is given for a statistician with the most significant contributions with age of low 40s. And she was elected member of International Statistical Institute in 2006, fellow of Institute of Mathematical Statistics in 2007. And then she also got the FN David COPS Award in 2017 for her contribution in mentorship. She was elected member in 2018 to the National Academy of Medicine. And of course, she has received many, many grants from NIH and other funding agencies. But just to mention a couple which are prominent, a merit award from the National Cancer Institute, which ran from 2007 to 2016, and then the NIH Outstanding Investigator Award, the R35, from 2015 to 2022. And she has done this, while publishing, really prolific, in a prolific manner, in her career at University of Michigan, first until 2005, and then as professor in the Department of Biostatistics, and later on in the Department of Statistics at Harvard University. She chaired the department in the Department of Biostatistics at Harvard from 2015 to 2018, I guess, if I had the days correct. She's also a member of the Broad Institute, which is joint with Harvard and MIT. And she chaired the COPS, which is a committee of presidents of statistical societies from 2010 to 2012. And she has served in many capacities in the National Academy of Sciences. And of course, currently she's a contact PI of the Harvard Analysis Center of the Genome Sequencing Program of the NHGRI. So I think, this is just a snapshot of what we can say about Dr. Lin. And it's really, an honor and a tribute, to us. And we're glad that she has agreed to be with us today. So, Dr. Lin.
Excellent. And first of all, I'm extremely honored and to attend the first data summit and public health, data science and public health summit after the pandemic. I know this is not easy to have an in-person meeting, so I'm very, very grateful and to come over here. And so your staff been wonderful organizing the whole trip. They take care of me extremely, extremely well. I'll be more than happy to come back to visit Columbia again. Thank you. And thank you, Dean, and for inviting me, and thank you, the chair, and for inviting me. It's a really great pleasure to be here. And so this I'll share with you, and for some of the work we have done and about the COVID, and also in particular, I'll share with you the 6 lessons and I have learned and by working in this field. So I will mainly focus on early phase of pandemic. So this talk will cover the following parts. One is the epidemic modeling and analysis of the Wuhan data and US COVID-19 data in the early phase of COVID, and my journey as a statistician during the pandemic, and also I'll provide the some of the reflection and the lessons I have learned. So this part of this talk is based on this invited article, which was published in the Statistical Science. So I'll share 6 takeaways. The first takeaway is the statistician and the data scientists need to be engaged in early phase and learn on the fly. So I'll share with you my experience of analyzing the Wuhan COVID-19 data. And so in the early February of 2020, and Chaolong Wang is my former postdoc. He is on faculty in the School of Public Health and of Huazhong Science and Technology University. And so because, as you know, in January and the outbreak of COVID, so I wrote him a message as checking how he and his family were doing. And then he was telling me he and his colleague were analyzing the Wuhan data. And so at that time, there was already 1 case in Seattle and 1 case in Boston. So just intuition told me the disease might spread. So I decided to join them analyzing the Wuhan data. And Pan is a former alum of the School of Public Health at Harvard. And so he just became the Dean of School of Public Health at of Huazhong Science Technology University, and Tang Chunwu was the Dean of School of Public Health at that time, and now he became the Dean of Medicine and in Huazhong Science Technology University. And so the work was published in the JAMA and also in the Nature. And so for example, this work got quite a bit of attention. And so for the JAMA paper has almost like 1,600 citations. And so I'll share with you what we found and then make some reflection. So this concept of the RT, this is called effective reproductive number, right now is a household term. And so basically if RT greater than 1, that is bad. So for example, RT equal to 4, that means that 1 person affect 4 people. So if RT less than 1, that is good, then that means disease is under control. So we analyze the Wuhan data using the daily number of cases, and so try to estimate the transmission. And so because the COVID was has a new mechanism, and so we need to address several emerging issues. And so if you look at the figure in the bottom here, so between the exposure and the pre-symptomatic onset, so we introduce a compartment called the pre-symptomatic onset. So this is called the latent period. And in 2020, that's about 3 years. And then between the pre-symptomatic onset and the symptom onset, and so then this period, the disease became transmissible. And so this generally about 2 to 3 days. And then because at that time, the lack of testing capacity. So many cases were not ascertained. So therefore, we introduced this component, uncertained component. The observed data basically is observed daily cases. And then we, using this Poisson partial differential transmission dynamic model, we basically model the daily count mean and using the partial differential equation. By building this partial differential equation, and one can estimate the RT number. So first, let me tell you about Wuhan. And so Wuhan is located in the middle part of China. And so it's a population of 11 million. It's a beautiful city. So the picture on the right, this is the spring of the cherry blossom. And so it's a gorgeous city in the East Lake. So something happened in the December 2019. So I'll talk about 3 features of the COVID. So first, it was highly transmissible. The RT value without intervention was, we estimate is about 3.54. So the first case was reported on December 8, 2019, and in the Huanan seafood market, and the market was closed on January 1st. So the bottom figure here is the number of daily cases. And so you can see before January 23rd, and the number of cases went up exponentially. And the estimated RT value was about 3.5. So that means that without intervention, and the disease was highly transmissible. And then the city launched the lockdown and with the traffic ban. And so you can see the RT value dropped, and but still was above 1. And then city did something really even more dramatic, and it launched the centralized isolation quarantine by converting many of the field, building 2 new hospitals and converting 16 field hospitals from the stadium and exhibition centers. And so this was the US, also did something similar, and also many countries also did something similar, and following the Wuhan model after our study was published and was posted on the medRxiv. And but the model at that time was different, because in Wuhan the people with the symptom and was admitted to the field hospital. But in the US, only people with a severe disease were admitted to the field hospital. And people with the symptom and also people with the mild symptom, and they were quarantined at home. So this model was different in other countries. And then this model was quite successful in Wuhan. You can see the RT value after this isolation and quarantine strategies, and would drop all the way and below 1. And so the second feature of the COVID in Wuhan was highly convergence. So we estimated about 87% of the cases were undetected in Wuhan. So basically, the number of detected cases was only in the tip of the iceberg. So if you look at the figure on the left, so the red indicated reported number of cases, and the yellow indicated the estimated the number of cases. We estimated about 87% were unascertained. Most of them were asymptomatic cases, were mild symptomatic cases. And so this result later on were validated using the antibody study. And the third feature from the Wuhan analysis was that at that time, remember, there was no vaccine. And so the public health and intervention was extremely important. And using multifaceted public health intervention, it helped stop the spread in Wuhan. Those interventions include the mask wearing, social distancing, lockdown, and isolation quarantine. And later on, this model is called the Swiss cheese model. And so this model worked well in Wuhan. However, implementation of those public health intervention strategy, as we all know, was very challenging. And so there's in many countries, and also the compliance was quite a challenging issue. And so by using this multifaceted intervention, public health intervention, and then the Wuhan got the cases down to 0 and in less than 2 months. And so what are the reflections? The first is during this kind of large scale disease outbreak, and the statistician and data scientists need to be willing to step in and be engaged early and learn on the fly. For me, it's a very steep learning curve. And I have limited infectious disease background, but if people are willing to learn, and things can happen. And also, it's very important to collaborate with domain scientists. In our case, collaborate with infectious disease epidemiologists, and then developing data-driven public health strategies and also public health policy recommendation. And also, from the early phase, we learned that fast response has to be made with incomplete information. As statistician, we always want to have complete information and high quality study as much as possible. But when we go to the field, and it's difficult to do, especially in early phase. So decision has to be made with incomplete information in order to control the outbreak at early phase. So I want to quote a few remarks from Michael Ryan, and he's the executive director of WHO, and who led the COVID-19 control effort in WHO. And I have very high respect for Dr. Ryan. And so in the March 15 remark, he said the speak Trump perfection. So perfection is the enemy of good when it comes to emergency management. So be fast, have no regret. So you must be the first mover. The virus will always get you if you don't move quickly. And if you need to be right before you move, you will never win. So after the early phase of pandemic, I really appreciate the comments he has made, and based on his own experience of controlling Ebola and in South Africa. And this is really true in COVID-19 pandemic as well. When we have a small number of cases, one have to react fast, and then that will help control the spread. So this is the first takeaway. The second takeaway is the pandemic has really amplified the power of open science and the real-time dissemination of research funding using preprint repository and social media. So in order to share the funding and with the world, and so we, as soon as we finish analyzing the Wuhan data, and then we posted the preprint and in the MedArchive on March 6th. And so we analyzed the data until the February 18th. And so I did not, and then I tweeted the funding. I did not expect that the result was very, very quickly spread across the world. And so you can see the very large number of download, a large number of PDF files, and then got into multiple policies and documentations and reported by a lot of medias. And so then the Harvard decided, then I had a meeting with the Harvard leadership in late February to share with them the Wuhan findings and what we found. And then later on, the Harvard decided to send the student back home early. And then just before the school closed, and then I decided to share the funding and doing the room seminar. And so at that time, basically very few room seminars, and the Harvard even did not have the license for a large number of room attendees. So we have to work with IT office to get the special license and to do the room seminar. And so this was on Friday. The school was closed on that day. And so I went to the building. I think only me and the technician, probably only 2 of us were in the building. And then I went to the technical, in the basement and gave this webinar. And then in this webinar, and besides Wuhan funding, I also showed that the healthcare worker in US, and they were not well protected. And with the PPEs they had. And then I did not expect those 2 slides was widely spread and during the weekend. And then on Monday, and then some physician and launched the national campaigns and for the PPEs.
And so just over a short period, over 2 million people signed up. During that period, I got to know a lot of physicians. And so it's really wonderful to see a little statistical talk and was able to help the community. And so this picture was taken from my talk and from this national drive. And also during that period, and so the many volunteers to help with the launching the real-time dashboard, and really a remarkable community spirit, including the Hopkins COVID-19 Resource Centers and COVID Tracking Project, USFAC, and our data. And so those dashboard has really served as a vehicle for public education and policy making. And so those basically the community effort really play a critical role in early phase of pandemic. And because at that time was the government, like a CDC's move was slow. And so this just really incredible community effort, but nobody worry about the credit. People just want to help. And our own lab has also helped with the effort and led by my former student, Andy Shi and Sheila Gaylor. And so we launched this website, which provide the real-time RT estimate at multiple level, country level, and the state level, and also the county level. And so this was featured in Nature in the summer, and also was published 2 years later. The publication took a long time. And so this is just the website is still alive now. So I just took a look at the website yesterday. And so this is RT estimate for the US. And so right now, the New York's RT value is 1.3. So that means the case is going up in New York. We need to be a little bit careful because of the new variants. And so here are the few reflections on open science. So during the pandemic, open science has really emerged as a hallmark of the fight against the pandemic. And we have never seen this before. And so the real-time dissemination of scientific findings are really at unprecedented speed with the preprint repositories such as bioRxiv and medRxiv, and also social media such as Twitter. Twitter at that time was really wonderful. Now, you know, we all have concerns about Twitter. And, so during that time, it was really wonderful. And so there's a real-time dissemination. So especially in the spring of 2020, so almost 7,000 COVID preprint were posted on the medRxiv. So the also open science platform really helped the scientific findings through timely and widespread attention from the scientific community and also the public, press, policymakers, and also guiding the timely and evidence-based public health responses, and also direct individual behavior. And so I got much more followers, and during that time, many of them are not statisticians. It's really great to see those general public become more interested in data and also in science. So this is the third takeaway. And so this is something I learned in a hard way, that a statistician and data scientists need to have the median public health communication training. So I never had this type of training, and it was a very steep learning curve. I can tell you how I learned it. So in March, after the preprint and was posted on medRxiv, and I got a lot of median requests for interview. As a statistician, my first reaction is to turn down all the median review. I turned down all the median review in March, and so then later on I found that the situation got worse, and then I realized probably it's not a good idea not talk with the media. So we need to educate the media, educate the public, help them understand the scientific finding. So I started taking the median review and in late March and also in the spring. So you can see this is a lot of median coverage of our Wuhan findings. And then I learned that it's very important to speak in simple language without jargon. And so the public services and also general public need a statistician and data scientist. And so I serve on the Massachusetts State COVID Task Force and in the spring 2020, and also later on in April, And in mid-April, I testified in the Science and Technology Committee of UK Parliament. I never talked with a senator before. And so this was the first time and talking with over 10, basically like senators and in the UK system, and explain to them the findings, but I have to talk it in very simple language they could understand. And so then later on, and the committee wrote a letter to the Prime Minister Johnson with the 10 recommendations. And so multiple of the recommendations I made were included and in the letters and to the Prime Minister, including pay attention to the non-symptomatic cases, asymptomatic cases. And also later on, I served on the WHO, the technology advisory group on estimating the COVID excess deaths. And the WHO released the excess deaths estimate in May 2022. So here are a few lessons I learned. And so to effectively help with the public policy, media and public service communication and training are critically important. I was never trained. And so with this type of training. And then retrospectively, I wish I could have those type of training. It was really steep learning curve. So I also learned that it's very important to communicate without jargon in the very most basic, simple language children can understand. So I remember that one time I was on the BBC interview, and then the host told me before the show became on air, said, remember the people listening to the show, they were family eating breakfast and with the children. So this really speaks well, the need of the communication. I have to really communicate in very simple language in 2 minutes. And so we have to keep the message simple, short, focused, stick with what you know. And oftentimes when one on the show, and likely you will be asked for challenging questions right on spot, and you did not prepare for. And so you have to learn how to communicate those challenging questions on spot. And so hopefully Columbia can help the faculty and the students with more communication and with the public and to do the public services, because this is critically important. And the fourth lesson I learned that as in academia, we know generally partnership with industry and the government can take forever to happen. It's challenging. And the people all want to develop this partnership, but generally take forever. During the pandemic, especially in the early phase pandemic, we found that this type of partnership became much, much easier because everybody want to help. And so this also create a critical role that to help controlling the pandemic. So by developing this type of partnership between academia, government, industry, and also civil society. And this also stimulates new collaboration. So I will use a few case studies. And so I collaborated with colleague Feng Zhang at Broad Institute, and also at Ben Superman, who's the CEO of Pinterest. And so we worked together, launched this app we called How We Feel app that collects the data of the COVID symptom, behavior, and testing result. And so because as academia, we don't have much experience in developing app at the professional level. Collaborating with Ben's group was wonderful. Everybody was volunteer. And then they have much more experience, know how to develop the app. And then the app was launched in a few weeks and make that available in Apple Store and also in the Google Store as well. So this would be impossible without this kind of industry collaboration. And then this app attract lots of users, and there's over 750,000 users, and also over 50 million responses. And also we developed partnership with the state of Connecticut, and they help attract users to the app, and we provide funding, shared them with the Connecticut state. And so the paper was later published in August and also was reported in several media, including the Harvard Gazette. And so those are the one thing we found is for those data, you can see the data is huge, 50 million responses. One thing we recognized was that sample size is not the most important thing. Even you can get a huge sample size, but selection bias is critical, especially during the pandemic. So then in order to analyze the data well, because the people who were able to receive the test, they were more likely to be sicker people, were at higher risk. And so therefore, in the analysis, we have to control for that and collect for the selection bias. And so I'm going to say that a little bit later about the challenges in data collection during the pandemic. And in this analysis, we found that male and was higher risk, and also people of color were higher risk, and also healthcare worker and essential worker were all had higher risk. And also through the pandemic, I learned a lot of new things by developing new collaboration. I got to know much more people I never thought I would know, and especially in the media and also in the government agencies, and also new scientific collaboration as well. So for example, at that time, there was a need to develop efficient pooled testing. And then I collaborated with colleagues at Broad Institute and UPenn. We developed this efficient algorithm for the pooled testing using this hypergraph factorization. And so this was really great. It's eye-opening to me. And so to learn this new technique and developing this type of new collaboration, working on important problem driven by pandemic. So here are the few reflections. First is that pandemic has driven unprecedented level of partnership between academia, government, industry, and civil society. And everybody just want to be a volunteer, especially in the early phase. And nobody think about the credit, just want to help the society. And also this have resulted in rapid development of digital tool and platform such as those dashboard and real-time data collection, analysis, sharing, and also vaccine and therapy development. And also they have resulted in new collaboration in new area, like example I showed you. And so those fostering this type of partnership and collaboration in years ahead will be important. That will improve our chance of better preparing for future pandemic. So this is the takeaway number 5 related to data. And we found that it's quite challenging to do good data collection and during the pandemic. And also the epidemic modeling and also quite challenging as well because the challenges in the data. So those calls for better data collection and also infrastructure building to prepare for future pandemic. So I'll illustrate using this case study. And so this paper was led by my former postdoc, Corbin Quick and Ronak Day. This was published in JASA. This is the Journal of American Statistical Association as a discussion paper, and in the December 2020. So in this paper, and so we analyzed the US data. And so we developed this, we call the multi-level epidemic model to account for incomplete data. So the goal is to develop a RT regression model, estimate the incidence and the over time, and by allowing the RT as a function of time, the policy, and also the covariates. So what are the challenges in the US data in the 2020? First, we have to account for time varying underestimation. So basically in the early spring, because of lack of testing, and so small fraction of cases were uncertained. Later on, when the testing became more available, then more cases were uncertained. So uncertainment probability is a function of the covariates, for example, like PCR test. And also, using the PCR test alone, we are not able to estimate the incidence. So therefore, we need to integrate the PCR-based data, which are more widely available on daily basis, and also serological data, which was survey. Those surveys were conducted by CDC at a few states at few time points. The second issue is the lagging issue. And so the data reported in those dashboard was just reported data, but there are unknown delay lag between the infection, pre-symptomatic onset, and symptom onset, and also testing, we don't know those lags. So we have to build a statistical model to account for those lags. And so as a missing data, in order to properly estimate the RT and the covariance effect on RT, and also estimate the incidence. So the data we used came from multiple sources. In the state level daily reported confirmed cases from the dashboard, such as COVID tracking and CDC data, and also state level PCR test result. Those are the PCR test data, the number of tests provided by each state at each county, and also state level serological study conducted at a few times as CDC. Because one only use the PCR data, one cannot estimate the prevalence. We have to integrate the PCR data with the antibody data. And also we got the data of the state containment policy, such as mask wearing and mandate, stay-at-home orders, and from the Oxford website. So we integrate all those data for the analysis. So how can we do the analysis? And we just use this two example to illustrate the challenge. And so suppose the true infection is called YT. Each day there are 100 people infected. In reality, because the lag and those 100 cases, you won't be able to detect them on day one. And so generally, the potentially confirmed on day 2, 20, day 1, 20, day 2, 40, day 3, 40. And then, so for the second day, 100 cases, and they are potentially confirmed on day 2, 20, day 3, 40, day 4, 40. So therefore, the total number of potentially confirmed cases on each day, day 1 will be 20, day 2 will be 60, day 3 will be 100. Because of testing capacity and other factors. Data we observe is those cities, and only 50% of cases observed. So the Y and A are all missing. So this is just, I have just 2 slides, statistical slides. Hope you live with me for 1 minute. And so this to help the statistician. So therefore, in order to model this data, so basically we have a transmission model, and we also the time-lag model. We also have uncertainty model. We also have the zero prevalence model. So we have those models for different part of the data. Observed data are the daily confirmed PCR cases and also periodic serological data from the CDC. So the missing data are those, the A's, basically those are the potentially confirmed true number of cases each day. And the estimation is conducted using the EM. And so what are the models? So for the transmission model, the Y, the true transmission, using the true infection. And this assumed follow a Poisson distribution. And with the lambda, basically called infection potential, those indicate the number of people at risk. And the W indicated the zero interval distribution. Those were estimated from the existing data. And then we allow the RT to be a function of the covariance. RT is a parameter here, it's not a data. So we cannot estimate RT first and regress on the covariance. That will not be right. And so we build in the data are the count. Those are Poisson data. So we allow the RT as a function of the covariance, such as the containment policy. And so this is, we assume this time-lag model using a multinomial distribution, and we assume uncertainty probability as a function of the covariance, such as the number of tests. And also, we also model the serological survey data and from the CDC using the binomial distribution. So here are the results from the Massachusetts. And so the top panel, A, the blue curve, the green curve indicate the confirmed cases. And so the blue curve indicate estimate uncertain cases. So you can see in the spring that a lot of cases were uncertain because of lack testing. And then in the fall of December of 2020, because the testing became more available, so you can see that the green curve here, and then they are much more confirmed cases, and then there are less uncertain cases. And so this pink curve estimates the total number of cases. And this RT estimate, remember RT greater 1 is bad, RT less than 1 is good. So in the spring, you can see the RT value is large, for example, 2. And but in the summer, things became better. In the second figure, this uncertainty probability. And so the blue indicates the number of tests you can see in the spring, and then the number of tests is pretty low. So that's why uncertainty probability is low. And then in the fall, the number of tests went up. So uncertainty probability went up. And so the last curve here is estimated prevalence, cumulative prevalence. And those green curves are the reported serological prevalence from CDC. So you can see the estimated curve go through the CDC prevalence, reported prevalence curve. So that is good. We can get a smooth curve across the whole year. And so we estimated in Massachusetts, 79% of the cases overall were uncertain, and the overall prevalence in 2020 was 7%. So how about the whole US? So the whole US on the left, this is uncertainty probability, and in the whole US. And so the overall uncertainty is about 50%. So in the US, we estimated about 50% of cases were uncertain. And in 2020, and the range from New York has the lowest uncertainty. Remember, New York has the largest number of cases in the spring. And so at that time, a lot of cases were uncertain. So that's why uncertainty rate was low. And then Rhode Island's about 80% uncertainty. On the right, this is overall prevalence in 2020. Overall, across the country, we estimated about 13% prevalence, and across the country, ranging from Maine about 2% to New York is about 20%. And also, we estimated U.S. containment policy on the transmission of RT. So the color represent different policy. So the red indicates a low level of policy, and high indicates the high level. So for example, if you look at the mask wearing, you can see that not many people wear masks in the spring, but more people wear masks later on in the summer and also in the fall. And also if you look at stay-at-home order, and so you can see in the spring, and there was a strong stay-at-home order, and then later on was relaxed. And how those policies affect the spread. And so the result here shows how the policy affects the spread. And so this is a change in the RT value. So the negative is good. So you can see if you look at a face covering, and here you can see the mask wearing help reduce the RT value. And also the stay-at-home order also reduce RT value. And so that is good. But here is just a regression analysis. One need to be careful in terms of interpretation, not causal interpretation. And the one thing we learned that during the pandemic, as a statistician, we all want to do random sampling. And so as an epidemiologist, we all want to do random sampling. But during the pandemic, very hard. When we go to the field, I think it's very hard. And so because people at that time were worried about living, right? And so the last thing they want to do is to get involved in a study, right? And so therefore, not many people are interested in getting involved in the study. And so the CDC serological study definitely is likely to be based on the convenience sampling, is likely to be biased. And so if you we also found the same thing in the how we field study. The sample size is huge. As I mentioned, we have over 500 million people, and the sample size large doesn't mean the sample will be unbiased. It's particularly true during the pandemic. And so you can see in the spring, because the lack of testing, people who were essential workers, healthcare workers, they were more likely to be tested, and people had a symptom, they were more likely to be tested. So that means they were more likely to be uncertain. So therefore, even we have a huge sample size, the sample is biased. So in the analysis, we have to take that into account. Okay, and so this kind of a data challenge, data collection challenge, and during the pandemic is a major challenge and difficult to address. And so also we found a similar thing, and in the WHO analysis of excess deaths, So here's estimated excess deaths. And so the overall, this is excess deaths between 2020 and 2021. So you can see the COVID deaths was estimated about 5 million, and the overall excess deaths is about 50 million across the globe. And so you can see we see a severe health disparity issue. In Africa, you can see not much data available in Africa. And so this self-deficiency really play a role in the analysis to address, and also the health disparity really play a role in the health deficiency. And also here's the estimated excess deaths rate. And on the left, this is estimated excess deaths rate by WHO. Excess deaths is basically during the pandemics, as you recall, many people lost access to healthcare system. And so people could not see the doctor. So therefore, the number of deaths one would expect should be higher than the regular deaths. Okay, so therefore, it's important to estimate excess deaths. So you can see that Russia, Purdue, all the way up, South Africa, and also US is all the way up. And also, if you look at the estimated absolute excess deaths, and the Indian is a way outlier, and also the US is way up as well. And here are the few reflections on the improving the epidemic data collection. And so the gold standard epidemiological studies are challenging to conduct during the pandemic, and including the data incompleteness, bias sampling, and inaccuracy. So this is just difficult to do, and to do a very good epidemiological study and during the pandemic. And we, as a statistician, we all want good data, and better data, how with better decision, with better health, with better outcome. And however, the best effort by statisticians and data scientists and using fancy analytic tools cannot fully overcome the major limitation in the real world data. So what that tells us is important to build new coordinated national and international surveillance, testing, and sequencing system. And this is easy to say, hard to do. And also, we need to address the data collection and the reporting issue, and including the completeness. So as you can see, I showed you the global data in excess stats. Africa, the data very, very limited, and also representative and the consistency. And the different countries have different system, and there's a consistency, data consistency is the issue. And also the bias issue in the data collection also need to be addressed. Also compatibility over time and also cross region. Many of those dashboards was shut down last year. And so those are all based on volunteer effort. So therefore, what should we do in the long term? So this is the takeaway, the last takeaway. As a statistician, we always say data science is important, right? But during the pandemic, I realized that implementation science is equally important as data science. And but implementation science, as a matter of fact, is much harder. So the data science we all know is important, but it's not enough. Data science definitely play a critical role in forming evidence-based policy and the disease and surveillance and the control. When I was a graduate student, I was told, let data speak. But after I was involved in the pandemic research, I realized that let data speak is not enough. This is not sufficient to fight against the pandemic. So implementation science is equally important as the data science. So the real world implementation, as we all know, is challenging during the pandemic. So we need to push more about implementation science research. And so in particular, for example, access to healthcare system during the pandemic is a challenging. And we all know logistics is a challenging. And so many difficulty for the patient access healthcare system. So that's why that is a significant reason of this high access death estimate from WHO. So just give you my own experience. And so how difficult and for those implementation science, and there's a logistic issue. And so you all probably know this news article about how the Patriot helped the Massachusetts governor and shipped PPEs from China and using the Patriot flight airplane. As a matter of fact, during that time, there were another 4 flights. So I work with Massachusetts state, and also we have a group of us and help make this happen. It's really amazing how many people help, and it's really a team effort. And so the whole team worked really together to help arrange 4 flights from Shanghai to Boston, shipping the PPEs. And so people never know the swab is the issue. Swab just little things, right? But swab, if you don't have the swab, one cannot do the testing. And swab shortage was a major issue. So this is the first flight leaving Shanghai Pudong Airport on April. In order to make this happen, and so the team have to work with the commercial airline, in particular, in this case, is Air Canada, because the charter flight was not available. And so the team have to work with Air Canada to convert the passenger flight to the cargo flight. You can see this picture. And then this is the picture when the flight arrived at the Logan airport. And then those supplies were shifted by armies in order to protect them, not be taken away by others. And so this basically is a few critical reflection. The effective containment policies are region specific, no size fit all. So the implementation science has to be tailored towards a particular region, towards a particular country. And so this requires decisive leadership, solidarity, and effective public health communication, and also partnership of all the stakeholders. And we all know during the pandemic, we learned in a hard way. Behaviors are very difficult to change. And but humankind has inherited interdependence. We are all in this together. What this tells us is we need to do more research in behavior research. We need to do more research in implementation science and also more research in data science. So I want to thank all my lab members, and it was really incredible during the pandemic. It was very difficult for everybody. And during that time, a lot of lab members, they all volunteered to help with the COVID research. And thank you everybody and for listening. Oh,
Well, thank you very much for that really enlightening and really engaging talk, extraordinary. It really shows, the power of numbers, the power of quantitative reasoning, but at least to me, actually, it shows that science and data science, but science in general is at its best when it's transdisciplinary, impactful when it answers important questions, and effective when it's disseminated in the right way. So I think your talk actually showed all that in a very effective way. So we're kind of running out of time, but we can take a couple of questions. And then, of course, after the 2 questions, there are more, which I'm sure there will be. We will actually take some, during the coffee break, and you can approach Dr. Lin to answer any questions you might have. But if there are any burning questions, 1 or 2, please.
So I have a question regarding public communication of data science. So do you face any situations that's people, scholars or public that's challenges or disagree on your findings, and how do you handle them? And the related question is, because the data is imperfect, so throughout the pandemic, maybe the finding, I don't know whether this is a situation that the findings may change throughout times, then this will increase, the scrutiny from the public about whether the correctness of these findings. So how to handle those situations?
I think several people in this room probably can answer that question better than me. And this definitely is very important issues. And so during the pandemic, definitely there are lots of debate, lots of disagreement. As a matter of fact, I think that is good.
And so it's good to have a debate, and then people can talk about the issues, and then talk about the problems and everybody face. I think we should encourage this type of the dialogue. And also, as you know, during the pandemic, a major challenge we face is the misinformation and disinformation. This has been very, very challenging in many different ways. And so a lot of public health researchers were attacked in many different ways. And so, you know, it is challenging. And there's definitely, as a community, we have to address those issues. And then how can we have a constructive and helpful and discussion, and without the scientists feel unsafe. Yeah.
Thanks for the call. I liked a lot what you said about the decision, having to make decisions in the face of uncertainty. And I wondered also about that. Part of the difficulty, it seems to me, is to convey that uncertainty to the public without telling them that we don't completely know. So the difference between what we know and what we think. And that's kind of what probably the difficulty is for people to ascertain. So I wondered also, how much of the medRxiv, has anybody has looked at how much of the medRxiv papers have actually been debunked or not been debunked? Because it seems to me that would be part of that uncertainty in terms of not DGRO to chloroquine, but something a little bit different.
So I fully agree with you. I think this definitely is a challenging issue, especially I encounter this type of issue in media review, when we interviewed in media. And so one thing I feel like we need to be honest, and so we have to be evidence-based, and think not what. So if it's what we think, we need to make it that clear. This is what we think. If this is what the science support, we need to be clear that is the science supported. And also for things we don't know, we say we don't know. So I think we need to be honest, but also be very, very careful. So sometimes, like I found especially like when we deal with the media, and then especially in articles, in like for example, New York Times articles, they interview you, they don't share with you the article they wrote before it appeared. Okay, so you got quoted, but sometimes the quote may be out of the context. So one have to be very careful. And so therefore this kind of like a media training is very important.
Great, thank you very much. I think it's now time for a break, but before doing that, please join me again in thanking Dr. Lin for an inspiring talk.